That's working. All right. We're going to start parasitology, and I'll tell you now, and I'll ask Dr. Mayer probably to send a general email. If I don't cover the very last lecture or parts of it, you've got the handout that will give you all the information that you will be needing. And it's just the extra explanations would not be there. But I'll also see if I cannot put something on the web so that you can access, sound bites as well. Okay? I don't think I'll be able to cover the last lecture, that just time is limited. Okay? So, we're going to talk about parasites, and you will recognize some of the names are weird, that you have never heard of it, some of the diseases you have never heard of it. But that, having said that, yes.
Do we have a handout for the bioterrorism?
Yes, no, there is no handout for bioterrorism, just, what I, covered in the class and the notes. And I think that he has got the soundbite. Jack, you recorded that. Sorry? You're not going to share that. Good idea. If they were here, they would not have missed it, right? It's not my idea, okay? He wants to sell those. And in return, he's going to give me a Clemson, Carolina ticket. Okay. I won't be in the country. By the way, I am not going to be in the country after the 16th or 15th, or, even the last Friday. This coming Friday will be the last day I'll be here. But my email will remain the same, so if you've got any problems or questions, send me an email, okay, and I'll be happy to answer. In the email, just put down MBIM 650 on the subject, because I get so much junk that I delete anything that I don't recognize. MBIM 650 in the subject heading, place, so that I recognize what it is, and I wouldn't consider junk, because all your names, I don't have it up here, who is in the class, so if it is just the name, I won't be able to recognize from the name. Okay? All right, so we're going to talk about some weird parasites and that are unfamiliar to you. Some of the diseases you may not even see, but what we were not seeing 10 years ago, we are seeing those here. Because of our troops being abroad, there's a lot of traveling involved. Troops come back and forth, okay? Medical, the staff goes back and forth as well. So lots of diseases that were uncommon are becoming more and more common now. What I have, again, the way the parasitic diseases have not received much attention because for a number of reasons, prevalence in developing countries and lower in socioeconomic population, and we don't see those diseases as they see in developing countries. Low mortality and morbidity in some of them are very high morbidity. And certainly a good degree of mortality as well. Limited drug developments. You will notice from the lectures that there are only 5 different drugs. 5 or at the very most 6 different drugs that are used for different parasitic infections. And you will see, and they will probably be in bunches that you will see those drugs. There are no vaccines for any of the parasitic infections that can be used. There is some effort to develop malarial vaccine, but there is not one, and leishmanial vaccine as well, perhaps, but there is not one that has been approved either in this country or any place else. They're all under either development, experimental models, or clinical trials. So that's the reason that you don't hear of those. In South Carolina, it is an old study that was published in those years. And again, there's not much research, so there's no new data. You'll see some roundworms in South Carolina. Good number of them. These are fairly significant numbers. Hookworms, you're going to see 1 or 2 cases have been seen at the VA hospital. So it is within the country, and more so in the southeast than any other parts of the country. Trichuriasis, you can see that, and we'll talk about those diseases. Giardiasis, I usually get 1 or 2 people in the class that have had giardiasis. Okay, so that's not uncommon either. And this is particularly very common among the HIV-infected patients. Interestingly, every year, third-year students or fourth-year students, if I see them in the hallway, they say, "Oh, Dr. Ghaffar, I saw a case of giardiasis that came in." Okay, so you're very likely to see those. Entamoeba, not as common as the others, but there are cases of those. And if people are traveling abroad, they are very likely to experience infections with those. If one looks at the universal incidence, there's a very high amoebiasis rate. It should not be coli, by the way. I'll correct it. It is Entamoeba histolytica. Okay? So if you want to correct on yours, if you've downloaded, I'll already correct that. It is histolytica. Okay? Giardia. Sorry? That one there. Instead of coli, it should be histolytica. Just oversight on my part. Okay? Bacterium coli. That's probably where I was thinking about when I put by mistake, coli. It's a significant number of cases worldwide, and most of them are in the developing countries where the poor hygiene, poor socioeconomic conditions, poor water treatment, poor sewage disposal, and so they are very prevalent, those places. Giardiasis, not just limited to those. Cryptosporidium, diarrhea, has become more and more common among the HIV patients. Ascospora, again, opportunistic, and it is seen in HIV-infected patients. Trichomonas vaginalis, very, very common. It's a sexually transmitted disease. So those are the protozoan diseases that we're going to talk about. The way I have organized the handout as well as presentation, we talk about the organisms a little bit, morphology, geographic distribution, and it is very important. I keep on emphasizing where the person has been or where the person has come from or where the person has immigrated from. So it is important consideration, and therefore you should know what are the areas that have that geographic distribution. I mean, to give you an example, if you have never been to Central Africa, you're not at risk of sleeping sickness, a disease that we'll talk about. So that's just an example. You can exclude certain things or include certain things based on the history of where the person has been. We'll talk about life cycle, and that is also, that tells you what the mode of transmission is and if there are vectors or reservoirs for those. Symptoms, of course, in order to diagnose and come up with what organism is causing those symptoms, you've got to know those. Pathogenesis and immunity, we'll talk about that. Diagnosis and treatment and prevention of these diseases. Since there are only 5 diseases and there are none new ones coming up, there's not much on the horizon. Do study and know the treatments as well. Okay? So, there are only 5 drugs, and they are just, as I said, historically, they have not changed. Amoebiasis means infection with amoeba. Etiologic agent is Entamoeba histolytica, and that has been disease, amoebic dysentery. But in addition, in chronic cases, there are liver, lung, and brain abscesses, and there may be some other areas of the body, anatomical sites of the body. Their abscesses may be seen, depending on where the organism has migrated, which tissue or organ. Here is a case scenario again. If you think that I should turn off the lights to projection mode, just let me know, okay? All right, if it is not visible to the back. Or you can just move forward. I promise I will not throw anything if you are asleep. Okay? And, and if you think I can't throw that far, that's wrong. Okay. A 37-year-old businessman complains of central abdominal pain, diarrhea, and flatulence of 10 days duration, which started 2 days after returning from a trip to Central South America. No effort to malign any countries, but that's where those infections are more prevalent. His wife and children who did not travel with him have no GI complaints. He has no fever, and the physical examination is otherwise normal. The stool and mucus, it contains mucus and blood. Okay? So, there are two things that you should be thinking. If you remember, Dr. Fox talked about mucus and blood. Okay? Or certainly mucus. All right? In shigellosis. Okay? Mucoid dysentery. No fever, unlikely bacterial infection. Okay? Although there are some cases of parasitic infection, GI infection, you may have low-grade fever. Key point is there. All right. The possible agents could be entamoeba. As a matter of fact, as we go along, we'll compare different GI parasitic infection as to how you can differentially diagnose. Histolytica morphology is here, amoeboid organisms, okay, and those are the trophozoites, means mature form, okay, and they produce cysts, and their cysts are round, and they have four nuclei. Up to four nuclei. In some cases, you may see a few more, and we'll talk about that. But generally, you can sort of think about four nuclei. There's a central karyosome in both cysts and the trophozoite. In the trophozoites, occasionally you may see ingested red cells. Where can they be found? Where are they seen? They are seen either in the stool. They're seen in the stool, actually. Not either, just in the stool. Okay? Because this is a GI infection. Life cycle is very simple. Orofecal, as one of our clinical instructors used to say, poops to mouth. Okay? So that may be easier for you to remember. Anyway, orofecal, okay, the infected individuals, in the developing countries, in many countries, the toilets may be outdoors and are outdoors, or if they're not, they're hiking or in the fields, they may just relieve themselves there. And that, of course, will contaminate the field, and it can find access to water or vegetation. And in some countries, not only that, but they also use untreated sewage for fertilization, or improperly treated. And I always tell a sort of episode that I experienced about 15 or so years ago. I was in Pakistan just visiting, and there was also a friend, a colleague, a surgeon friend. He was also visiting his family, and we used to play tennis here, so we decided to go and play tennis in Pakistan. It was July or August. It's impossible to live there in July and August, certainly outdoors. It's hot and humid. And we lasted only about one set, and then we decided we'll quit. Went to the little shack there, and we said, could we have a drink? Sorry, we are not open. Do you have any water? No, they don't have any water. So we came out of there, and there was a gardener, watering the beautiful lawn. And we said, well, can we have a drink from that? No, you cannot have a drink from that. Can we wash our hands or face, cool off? No. Why? Because it was not treated water. Okay? So that's not uncommon in many countries to use untreated water for irrigation. Even the city water is often not safe. For the last, nearly 2 years, I've been using boiled water for drinking or filtered, 3-stage filtered water. So the city water is not trusted either. Okay, so orophycal is the mode of transmission. Okay, once it enters the body as a cyst, okay, most of the time cysts are infective. The chromosomes, the nuclei, 4 nuclei divide into 8 nuclei, and then they start dividing, and those dividing cells with a single nucleus, they transform into trophozoites, and the trophozoites are the ones that cause problem in they attach themselves to the mucosa, intestinal mucosa, and sometimes they even might invade the tissue and lodge into different organs, thereby producing cysts. Okay, and then they will also turn into cysts, and those cysts will divide their nucleus and become 4 nucleated cells with 4 nuclei, cysts with 4 nuclei, and they're extruded in the stool, and that's the infective form of the organism. So the infective form of the organism is cyst. Small and large intestine is normally involved, and there it will produce abdominal pain, frequent bloody dysentery, and bloody is underlined, sort of emphasized, because there is often blood in these tissues, in these stools, and it may also and often does contain a necrotic mucosa because of the destruction to the gut epithelial cells or gut mucosal cells. Okay, the other organs that are involved is, that's just okay. The symptoms, of course, will be the same thing. That's a repeat of that for some reason. In liver, if they invade the tissue and end up in the liver through circulation, they would cause cysts, abscesses, and, of course, inflammation of liver. In lung, again, they will cause abscess and pneumonia. In brain, abscess and encephalitis. So those are just straightforward. Wherever they are going to cause abscesses, and because of the presence of foreign body and an organism, there will be inflammation, which will result in hepatitis in liver, pneumonia in lung, or encephalitis in the brain. Pathology of the organism is invasiveness and abscess formation. Both of them are due to amoebic proteolytic enzymes. And there are some varieties of amoeba histolytica that are much less virulent than the others. And virulence is usually, the degree of virulence is usually correlates with the size. The larger ones are more virulent, and production of the proteolytic enzyme. That's what digests the tissue and causes abscesses. Immunology, antibiotics are detectable in chronic infections, but they are of questionable value as protective antibody, protective immune response. They are not really very protective. Amoebiasis is different from giardiasis as a differential diagnosis, and bacterial dysentery. There's mucus and blood in the stool, and there are no or granulocytes to mention of found in the stool, and no granulocytosis in the circulation either, and no high-grade fever. There may be low-grade fever. Those two are characteristic of bacterial dysentery, which is shigellosis. Okay. Diagnostic features are, I've already mentioned to you, sort of irregular and multiple forms of it. There is a think self-study or independent study scheduled, which, if it is, you have not got it on the schedule. I don't remember if it is or not there. Dr. Mayer will probably send you an email. You can go over, it's a self-study, but it is part of the independent study. And you can go through the laboratory exercise and see different organisms in their different diagnostic forms. You can look for it and send an email to him. It's automatic test. You take a little quiz and it goes to him as a results, part of the results. That would be very, very helpful for your test within this course and outside this course. Because most of the time, these diagnostic pictures, they come up with a test. Okay? Case scenario, and given this one as a, what is the organism, or some other question. Okay? So it will be very helpful for you to go through that exercise, not only just to complete your independent exercise portion of the course, but also for the exam. These questions for this part of the course will be included in virology section. Okay? One has to be careful. There are lots of amoebae that can be found in the stool. I will not hold you responsible for remembering all the characteristic features of these organisms. They are morphologically different in terms of their number of nuclei in those, or the size or position of the karyosome. But if you remember but you should remember the organisms that are not pathogenic, and they are part of the differential diagnosis. Because the lab itself would identify that. A few years ago, I got a call from Richmond, a physician, and they had a immigrant Russian child, and they got the report. They were sent a report from the lab, one of these organisms. I think it was an Amoeba bushlii. Okay, and they said, well, should one worry about it or treat them? No. Okay, that was a normal commensal organism. Okay, so I've already said that, how they are distinguished. Okay, prevention and treatment are better hygiene, efficient sewage treatment, and proper disposal. And treatment, iodoquinol or metronidazole. Those are the two choices. I have excluded some of the pictures from it just to save some time. And I may, if I have saved some time towards the end, I will, go through that. I may not have time. Giardiasis, etiologic agent is Giardia lamblia, sometimes referred to as old man giardia. You will see why. Disease, diarrhea, lipid and vitamin B12, and other nutrient malabsorption. Okay? Those are the, and in turn, of course, they will create the symptoms depending on how depleted those components are in the patient, depending on how, okay? Slight change from the old one. First, business complaint of central abdominal pain, diarrhea, and flatulence, 10 days, which started the day after returning from a trip to Leningrad. Leningrad had to have a very bad reputation for giardiasis, but that is not the only place. You can go to Colorado or Montana, and if you are in the wrong place and you do the wrong thing, you may come back with giardiasis. Okay? So Leningrad, although Leningrad was particularly famous at one stage, I don't know after the revolution or after the changes in Soviet Union how bad it is. Okay, his wife and children who did not travel, again, did not have the complaints. He has no fever and physical examination is otherwise normal. Milk consumption makes the symptoms worse, so lactose intolerance is associated with this infection. The stool is bulky, foul-smelling, and floating on the water surface. In other words, very low density. And those are characteristic features that should make you think of not amoebiasis, but giardiasis. Most importantly, no mucus, no blood. Okay? And the texture of the stool, another characteristics of stool should make you think. What is the prevalence? Children are very prone to getting it, and this is not from overseas. This is from the country, from the U.S., these numbers. Okay. It's not reportable in either South Carolina or North Carolina, so you don't see much data. Not strictly reportable, but there's also the physicians sometimes do report those. Or these specimens may go to DHEC for analysis, and they have a sort of underestimate of these incidents. Children, and then between 6 and around 20, there's a lower incidence. If it starts going up between 21 or 25 and 40, people are more active, and they are hikers, outdoors people within that age, and then it starts going down. And as I mentioned to you, this is from the MMWR report, in 2000. There's no reason to believe that it has changed. As people are more sort of indoors and so forth, it just goes down, unless there's HIV as an infection and immunosuppression as a result of. About 11,000 cases have already been reported this year, and there were about 65 in South Carolina. Okay? So it is often seen. And again, those numbers are not real numbers. They are gross underestimate, because there's of no legal requirement for reporting. Morphologically, it's a pear-shaped organism, and that's the reason it's referred to as old man giardia, sort of bald, with a few strands of hair, glasses there, all granite glasses, round frame, and sort of tail, straggly beard. Okay? So you can't mistake that organism if you see it. There are about 8 or so, 8 flagellae. In the stool examination, you will not often see flagellae. It's got to go to, electron microscopy or much higher power. Okay, it also produces a cyst. Then cyst contains a lot of features of the trophozoite. Except nuclei have multiplied, and there are 4 nuclei in the cyst, and in the lab exercise that you will go through, both cyst and trophozoites have been are represented. Flagellae, parabasal bodies, those are also, as you can see, in axostyle, sort of primitive axostyle there, okay, in both of them. So that's the general morphology. The cyst, instead of being round, is oval, egg-shaped. Size-wise, there's some overlap with that, but by and large, it is smaller than Entamoeba histolytica. Life cycle, same as Entamoeba histolytica, orofecal. Okay. The difference is there are beavers and some other animals have been, wild animals have been reported, documented as reservoirs. A typical scenario: you are hiking, somewhere in the mountainous or hilly area. Montana is particularly mentioned in some of the texts, but it could be in South Carolina. Okay, somewhere in South Carolina, there's a nice clear water stream coming from uphill, and you're thirsty, and you just go down and you may wash your face as well as drink some water because it looks very, very clean. And however, it may contain the cysts from fecal material of reservoir animals, those carrier animals, and a few days later, you can come down with severe diarrhea. Okay, symptoms are it is confined to the GI tract. In the acute infection, flatulence, foul-smelling, bulky diarrhea, light diarrhea, low density, floating characteristic, malabsorption, lactose intolerance are the sort of symptoms, which I have already mentioned once before. Okay, in the case of chronic, small and large intestine, the same area, asymptomatic or mild to more severe symptoms, and it may be cyclic. Okay? So that the people may become chronically infected with the organism. Pathology, it is not invasive. It simply covers the GI tract. In the morphology, there was a suction area that is function as a suction cup. And these organisms, they attach themselves to the gut mucosa, and by virtue of doing that, they make the gut lining flat. Okay, so the villi become fewer or disappear, and flattening, and that will of course cause not just presence of the organism, but also flattening of the lining would cause malabsorption, because the surface area is reduced and also is covered with the organism. Okay, immunologically, some protective role for IgA and IgM has been described. Okay, and that's the reason that the HIV individuals are much more susceptible to this. Increased incidence in immunodeficiencies. That's what was next. Okay, differential diagnosis. Yes, it's different from amoebic and bacterial dysentery. And the two characteristics: no mucus, no blood, or PMN in the stool, mucus and blood in the case of amoebiasis, blood and or mucus, and PMN in the case of bacterial dysentery or diarrhea. No granulocytosis and no fever is common. Okay, is common feature. Again, this is the real stool instead of a drawing. Representation of the organisms. Most of the time you are likely to see stool likely to see cyst in the stool, because the trophozoas reside in the upper, and they are attached into the upper part of the intestine. There is a test, entero test, I think it's called, It's in your handout. I think I've got, okay, in your handout, where one makes the person swallow a gelatin capsule, empty gelatin capsule, swallow it, but it is tied to the string, and after swallowing, sometimes after, one pulls it back out so that it has gone beyond the stomach, and then one can pull it out, and then whatever comes with it is, is absorbed onto it. If one puts on the slide, one can see these as well. Okay? Very high-tech test. Just a string, okay? Okay. Prevention based on better hygiene and efficient sewage treatment and efficient disposal. Those are the preventive measures. Those are the two really organisms that are really most common. Okay? Iodoquinol or metronidazole are the drugs of choice. Yes?
These two organisms that we talked about,
yes.
Like self-limiting, or do they have to be treated?
As you saw in the... No, they should be treated. Okay? Because antibiotics can result into chronic and abscesses. Strangely, my wife is from Denmark, and her brother was assigned to a job in Africa. And he came back and he could not walk, and he had trouble walking, and there were some other symptoms that suggested that there may be an abscess. Okay? And they could not identify it for the longest time. And then later on he was treated for amoebic abscess, and his symptoms disappeared. So, yes, lack of treatment can lead to abscesses in different parts of the body. So it should be treated. Mild giardiasis, if it's a mild case, it may go away. But most of the time, you do want to treat.
If it does become chronic, does that hinder the treatment at all, or is it just as effective?
Obviously, the more severe the infection, the longer the treatment. Okay? So, but they are not. I do not know of any drug resistance in either of those two. Okay? They're both treatable. Okay. The next protozoan parasite that we'll talk about is intestinal protozoan, Balantidium coli. And it's a zoonotic infection. And Cryptosporidium parvum, that's becoming more and more of a problem due to HIV. The HIV individuals are often infected with, have Cryptosporidium-mediated diarrhea. And very difficult to treat as well. In the normal individuals, normal population, heavier doses of infection can produce symptoms. Historically, several years ago, it was reported, there was a lot of rain and flooding in Wisconsin area. And because of that, the sewage got contaminated. The water got contaminated, okay? And there was a large epidemic of cryptosporidial diarrhea. And when Dr. Bryan comes, he will also emphasize, if you see within a community that there is a lot of diarrhea cases, okay? A lot of diarrhea, community diarrhea, suspect Cryptosporidium as an infective agent. I may have some slides to show. Often there was one or two cases reported that where the office individuals, okay, from our office, a good number of them, I think it was over 20 individuals working there, they came down with diarrhea, cryptosporidial diarrhea. It was self-limiting. These are normal population, okay? So, but it was traced to the water bottle. Once the water bottle was changed, there were no new cases. And some of those cases, Cryptosporidium was isolated from that. So, large group of people within a limited environment, think of that. I don't remember if it is true or not, if they were reported, but I have a suspicion that there were some cryptosporidial diarrhea was reported after the Hurricane Katrina. Okay? So it is not an insignificant organism, particularly when we are thinking about HIV individuals. This is also an opportunistic infection, and you will often see in context with HIV-infected individuals. Beneltium coli, primarily zoonotic. Horses, pigs, and cows are carriers. Farm workers are at a risk. So if you see a farm worker and you see the conditions like amoebiasis, diarrhea, they think also of Beneltium coli. Symptoms similar to amoebiasis, except that there is no invasion. Okay? No invasion and no abscesses. Here's the typical picture. It's a ciliated organism. It's a ciliated organism, and it's a lot larger, up to about 3 to 4 times larger than Entamoeba histolytica. The cyst also has primitive inside the cyst. If you're lucky, you can see cilia. The nucleus is sort of kidney-shaped, they're large, relatively large. Okay? And there are no central karyosomes in this case. It's very distinct from Entamoeba histolytica or Giardia, as you can see. Here is the life cycle, normally zoonotic. Here is a pig, and one pig carrier or has the infection, and it will spread into the whole herd. And occasionally people working on the farm are going to get infected, and they will have symptoms, and there will be cysts in their stools. Very simple life cycle. Symptoms, as I said, similar to amoebiasis, with a diarrhea with blood and mucus, except no abscesses found, and the organism is obviously very distinct from Entamoeba histolytica and easy to recognize. Okay, here is a sample from this stool specimen, both of those. Prevention, of course, good hygiene, avoid the ingestion of material contaminated with animal feces. So washing hands is very important, for the wife who's making the salad, or the husband who's making the salad while wife is working in the yard, in the barn. Okay, so either way, if the food can get contaminated, a person is at risk or can acquire the infection. For some reason, tetracycline is also one of the agents can be used, but if you can remember the iodoquinol and metronidazole, which is for the other 2-3 protozoan parasite, you're safe. Okay? Or you will be able to help the patient. Here is the Cryptosporidium incidence that I was talking about. Okay? Around this time, and it's not seasonal either, nothing to do with seasonality. There were a large number of cases here. All right? And some were just symptomatic, others laboratory confirmation by finding Cryptosporidium. And there are epidemics or limited endemics, okay? Limited epidemics, I should say, really, are often reported for this organism. And this is with the normal individuals. If it was HIV-infected individual, of course, it won't be self-resolving. It will be major nuisance. Animals are a reservoir for this. Therefore, if the animal fecal material contaminates drinking water due to a major flood, major hurricane, or if it contaminates the drinking water in a water bottle fountain. Okay, this was 2005. Okay, there were 15 cases. Okay. All right. Morphologically, this sort of stains reddish, sort of with eosinophil, with HNE stain, and here is the cysts that are found. It does not have a really trophozoite form. It's the nuclei multiply within the cyst, multinucleated. They burst and produce the more young cryptospordia. Treatment and control is self-limiting among the healthy individuals. It may be asymptomatic or symptomatic. Severity of symptoms will depend on what the infectious bolus of infection is. Severe and prolonged in HIV disease patients, very difficult to treat. Pyромycin is often used, but there may be other newer drugs that can be used, but it's very difficult to treat. Proper sanitation and clean water supply are the preventive measures. Okay, so that is cryptosporidium. I'll finish this, within in the next couple of minutes. This part. Isospora belli is another sort of oval protozoan parasite. It's often you will see binucleated, large nuclei, and that's also an opportunistic organism. Actually, those are not nuclei, sporocysts. Those are spores. Okay, and it causes giardiasis-like symptoms, but milder symptoms. You don't get as blatant or as severe flattening of the gut mucosal, gut epithelium, and also the symptoms are a lot milder. I do not know if you get glucose intolerance in this case as well. I have not seen at least reported that way. So that is another feature that you don't see with that. Diarrhea is the only common feature. Causes giardiasis-like milder symptoms, self-limiting in normal individuals. Again, opportunistic infection. And anything, when I say opportunistic infection, you can right away think of HIV individuals that would be extremely susceptible to it, and it will cause major problems in those individuals. Okay, severe, as that's what I just pointed out. And in this tool, that's what you're going to find: typical oval protozoa with one or two sporocysts, and that's how they divide. They replicate. Diagnostic stage: fresh stool with one sporocyst. Treatment: TMP, trimethoprim, sulfomethoxazole. You will see that drug again and again in terms of HIV individuals. That will be the treatment, of course, in the HIV individuals who are not going to recover from it spontaneously. This is a drug used in pneumocystis pneumonia as well. Well, you'll see it later when one of our clinical colleagues is going to talk about AIDS. We'll take a break.